Top Med Talk.
Nick Majerison here. Welcome to Top Med Talk. This piece is taken from the Perioperative Medicine Shared Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com for more details. Have a listen.
I would like to introduce you to our next speaker, Dr. Vincent D'Antini from Alfred Hospital in Melbourne. Dr. D'Antini is a senior staff specialist in the general medicine and nephrology at the Alfred Health and also the head of our perioperative unit. He has got a keen interest in perioperative medicine and acute kidney injury, and he will be presenting on goal-directed therapy to prevent acute kidney injury. Thank you, Dr. D'Antini.
Thanks, Arka, and I'd like to thank the organisers of this meeting for inviting me to talk about something I'm very passionate about, and I'd like to thank everyone in the audience too for listening in as well. So I'm very much interested in acute kidney injury. I'm a nephrologist and a general physician. I'm actually on call today and we're doing a lung kidney transplant, which I'm rushing to after I finish this talk. But getting on with this, I'm very excited because acute kidney injury has been huge, and in the last 20 years it's just come alive, because prior to 2000 we used to use a term called acute renal failure. And prior to 2000 there were about 30 definitions of acute renal failure: doubling of creatinine, 1.5 times creatinine, all sorts of combinations, maybe a creatinine of 1,000, or is acute renal failure when you need to start dialysis. So in 2000, a group of interested experts got together and they formed this ADQI, Acute Dialysis Quality Initiative, in the red there, and they were from representing Europe, Australia and America, and they got together and they laid the foundation for what is now acute kidney injury. The same group expanded, and in Amsterdam in 2007 they all convened and come forth with some really good definitions and classifications, and I was very fortunate enough to be involved with ADQI and ADCIN as a very young fellow. And then from then on you can see that AKI is well known and everyone's aware of it. But AKI still flies under the radar. We have a definition, it's pretty vague, but it's a heterogeneous disease with a sudden loss of renal function. And it's pretty common, affecting 1 in 20 people in hospital and a third of the population in intensive care. And it is increasing. Yep, we've got our multimorbid, older patients with a whole lot of new drugs that affect the kidney and affect the patient. And most importantly, it is preventable. And in a lot of studies it's shown that up to a third of acute kidney injury is preventable. When you do get it, it's expensive. Length of stay, dialysis resources. And very importantly, in my renal practice, when I ask, is there a family history of polycystic kidney disease, hypertension, smoking, diabetes, etc., one of the risk factors now is, have you had an episode of acute kidney injury? Because it is a cause of chronic kidney disease. And this is the new wave coming. Sadly, there is no effective treatment, there's no silver bullet, and all we can do is really support the patients. We would love a troponin in acute kidney injury. We've had, over the last 10 to 20 years, lots of molecules have been discovered, and we've tried them, and we'd love one that to be sensitive, specific, and also prognosticate. And we've tried a whole lot of, some have heard of NGAL, KIM1, kidney injury model, etc., etc. However, none of them have actually come to clinical utility at the moment, and we're still using an old criteria to classify acute kidney injury, in that of serum creatinine as well as urine output. So serum creatinine has been used since the dawn of time. Unfortunately, it's not a great marker for kidney function, especially in a critically ill patient or sarcopenic patient, where it really does not reflect the kidney injury. We also know that creatinine can change up to 10% every day, and there's interlab variability. But it is cheap. You can use it historically to see where the creatinine is trekking, and it's universally available. So we have now these 3 stages of acute kidney injury: stage 1, 2 and 3. Stage 1 is it's just a small increase in creatinine, and it's only that of 26. And this is significant because of a landmark study that came out around 2006 and 2007, where someone actually looked at a database of a hospital and found out that people who actually had an increased mortality, the lowest rise in creatinine was up to 25, and they were actually at risk of mortality. So this is why a small change in creatinine puts you at risk of morbidity and mortality. I'm not going to talk about the causes of acute kidney injury in this lecture, except that we still use our simplistic paradigm of a pre-renal cause, a post-renal cause and an intra-renal cause. We know that AKI is a very heterogeneous disease, and we really don't understand what goes on in the kidney, to be honest. We know the medulla is very, very sensitive to low oxygen levels, and we know that there's flow disturbances, but the models we use in research are things like ischemic reperfusion, but that may represent what is actually happening to our patients. What is important is that despite all the studies in the last 20 years, that if you actually have dialysis requiring acute kidney injury, or stage 3, or when the rifle criteria LE, there is a mortality of 30 to 50%. And despite all the trials of different doses of dialysis, timing of dialysis, we still have a 30% mortality if you do end up getting into stage 3 acute kidney injury. This is serious. Going back, one third of AKI is preventable. So AKI is all about measuring the creatinine, a little change in creatinine, detecting it, trying to do something about it. How well do we do it? Well, this lovely study from 2009 from the UK, it was a national confidential inquiry into patient outcome and death, asked how good are we going? Well, we're pretty poor at identifying the people at risk of AKI. When we do detect AKI, we're pretty slow at, actually we're very slow at detecting it, but we're also very poor at implementing the appropriate management in only 1 in 2. Is it avoidable? In 30%, they found, yes. And do we make the right referral? This is not a renal physician and nephrologist problem. This affects all of us across the hospital organisation. And you can see that in elderly medicine, all the way to palliative care, surgery, cardiology, AKI is present in all of these specialties and including all the stages of 1, 2 and 3. So when we talk about goal-directed therapy, it's not just the nephrologist, but it's really the whole organisation, all of us, from our interns, medical students and anaesthetists, everyone involved, to be involved in the AKI detection. So we're focusing on periop here, and this is the journey where the patient's journey starts from pre-op all the way to discharge. And if we're goal-directing and saying, let's try to prevent AKI, the first thing we want to do is we identify if the patient's at risk. My next slide will tell us that the usual suspects are the ones that are at risk. Do we do a baseline creatinine? Do we need to do a urine sediment, checking for red cells or protein? Have we optimised the medications? We've probably had a whole weekend on, preoperative care, how important it is. And should we avoid nephrotoxins? Does this patient really need contrast just before going to theatre? And is the sepsis under control, which is a major risk factor for propagation of AKI? This is the prevention basket, the prevention overarm that reaches across all the way to discharge. What happens in theatre, as you can see, is also very important in propagating or preventing AKI. I probably won't talk about that. I don't know much about that. It's above my pay grade, so I won't make any comments there. But certainly at discharge, we can certainly pick up the patient again and make sure that if they did get an AKI, should we be seeing them again, checking their bloods to see if they're left with chronic kidney disease? And do we need to make adjustments with medications in order not to propagate and still prevent further AKI? And of course, there's intervention, which unfortunately there is no cure there. So, yep, this is the guy this is the usual suspect that's going in to having some surgery. These are the classic risk factors that are present that actually can affect all organ injury. So whether it's lung, cardiac, etc. The only one I'd highlight is chronic kidney disease, especially advanced chronic kidney disease, are particularly at risk of getting a pretty nasty acute kidney injury problem. So we already have algorithms on who we need to do a baseline creatinine on. So it's not for everyone, but clearly when we identify risk factors, they're the ones that are in prime position to have a baseline creatinine, as well as the type of surgery they have. These algorithms are right across our journals, and we're all aware of these. And it's important to do a serum creatinine after the operation so we can detect AKI. So let's talk about medications, and this is where the controversy continues. And we know that we don't want hypotension and we don't want hypovolemia. The kidneys are a wet organ, and it really needs to have preserved blood flow. Fortunately, it's pretty smart and auto-regulates. But when you have acute kidney injury, or when you have certain medications that can block the renin-angiotensin system, it's going to be very hard to auto-regulate, and it predisposes you to problems with hypotension. So it's very controversial. We know that we can continue beta blockers if someone's got ischemic heart disease. We certainly recommend that, and we think there's some benefits for statins for all sorts of surgery. But we really need to be prudent about minimising exposure to nephrotoxins, and if AKI is present, that we need to adjust some medications. So we start with the classic ACE and ARB. Do we withhold or do we give? So the latest guidelines are still a bit old, from 2014, and they said, well, it's okay to give them. It's a good level of evidence, but at the moment we think it's okay to give. So a lot of people do give ACE inhibitors on the day of surgery. People in the audience might think, really? Do people do that? Well, I'll show you some data in a minute. But that was 2014. I think those guidelines are due for another look at and probably need to be rewritten. But in 2017, a lovely paper, although it's observational, come back, but it's good numbers, have shown that actually if you withheld your ACE or ARB, you actually reduced the primary composite endpoint of all-cause death, stroke and AMI at 30 days, and also and so you lowered your risk of post-operative vascular events. So this was withholding the ACE or ARB on the day of surgery. And then this year has been a gold rush for great papers that have come out for AKI. And this was one of them where it's retrospective, but it is multi-centre and a cohort study. But these are people that actually gave the antihypertensive on the morning of surgery, and they basically found that it was independently associated with post-operative risk of AKI. So here we have a paper, the one in 2017 said we withheld and things went well. Here we gave, things didn't go so well. So I suspect that the next guidelines might be possibly not to give. But this was very clever. They got some experts in England last year, and there was about 200 of them, and they were invited periop physicians who are in physician trained or medicine, as well as anaesthetics, and they're predominantly from the UK. And they took on a survey saying, what do you feel is best and do you think is safe about giving an ACE or an ARB on the morning of theatre? What is your practice? And interestingly, so this is pretty new, this is pretty recent, 50% of the so-called periop experts would withhold the ACE or ARB on the day of surgery. If you follow the red even further, you might find that there's another 20%, so up to 70% actually would withhold. However, there's still 1 in 3 that continued to give the ACE or ARB on the day of theatre. So, and then they asked them some other questions, but basically the people who are more cautious or conservative would tend to withhold the ACE inhibitor for some time. So really what we know from this is there's still widespread uncertainty, even amongst experts, about what to do with ACEs and ARBs in the perioperative period, and really we need a large randomised controlled trial. The lack of clarity in consensus continues, particularly with diuretics. We know they can affect all sorts of things, including volume state and electrolytes. Once again, there's no consensus on whether to give them. Patients with heart failure, they recommend that they should be given their diuretics on the morning before theatre. We know that intravenous furosemide can save us pretty quickly, but when a patient is actually oliguric, we tend to reach for the furosemide vial, and it probably does produce urine, but there's no evidence of its benefit. And I just remind you that we want the kidneys to clear the blood, so that's at the glomerulus, and the diuretic actually works in the tubules. So tubular urine is not really as good as the glomerular urine. So it's very important. But it does make us feel good when we do give Lasix and urine comes out. So I have to say that. And we stop getting phone calls. It's very important that if AKI is present, that we do adjust or cease certain medications. I know there's a lot of medications here, but I just want to highlight about the diabetic medications. We always get caught out with the metformin still being given, and also be careful with allopurinol and digoxin. Right, so intravenous fluids and AKI, and the controversies continue. Fortunately, 2017-18, great studies have come through, which I'll go through. So we're really not sure still what type of fluids and how to give the fluids, and how we're responding to how we're giving the fluids in AKI. So we've been using fluids nearly for 200 years. Dr. O'Shaughnessy, during a cholera epidemic in 1830, put some salt in some water and saved half of England. And then we sort of got a bit commercialised, and the physiologist got involved, and we got some saline. That was 120 years ago. And we've had a little bit more development, and we've become a bit more physiological with our fluids, as we've got Hartmann and Ringer's lactate. Now, if you can see there, we've had these fluids for nearly 100 years. But as we're anaesthetising, as we're giving perioperative fluids to our patients, we're still really not sure which is the best fluid to give these patients, in particular to prevent acute kidney injury. As you can see, we all know this, there's a lot of chloride and a high amount of sodium in normal saline, usually our preferred fluid. And we now know that chloride, unfortunately, is looking like being the devil with its effects in the kidney. But now there's some evidence coming along about balanced or physiological fluids being somewhat better. Let's go through them. We knew around 2000, when it was early goal-directed therapy, which is with aggressive hydration and maintaining MAP, we found out that actually had no effect on mortality or need for renal replacement therapy. We also know that fluid overload is very bad. Swollen kidneys, compartment syndrome, decreased renal perfusion, venous engorgement are all bad for AKI. And there are numerous methods to assess fluid responsiveness, but unfortunately in isolation, one is not perfect. So I've got lots of those gadgets, but none of them are perfect to help us along. But in the end, we need to use our IV fluids judiciously, and in patients with AKI, be careful if they're not fluid responsive. So, colloid versus crystalloid. In 2004, the SAFE trial, a very good trial centred out of Australia, New Zealand, told us that crystalloid is as good as colloid, except for certain situations. And crystalloids is probably the way to go over colloids, because we know that colloids is expensive. However, we still have a lot of use of colloids or albumin in our practices, and it's usually because of a culture or doctor's preference. And despite the good evidence, that was in 2004, and then the Crystal randomised trial came out, and that was in 2013, and that compared effects of fluid resuscitation with colloids and crystalloids on mortality, and they also found out no difference in renal replacement requirements or mortality at 1 month. So once again, crystalloids look like they're in, colloids seem safe, more expensive, and the next question is, what type of crystalloid? Are you using a balanced or a balanced solution, like a Hartmann's or Ringer's lactate, versus a normal saline? And as I said, hypochloremic metabolic acidosis is certainly on point with research and looking at its deleterious effects. And we know in animal models that it affects the kidney, and also in human models that it affects the kidney with decreased renal cortical perfusion and in salt loads patients. So the Saltum study, published this year addressed crystalloids versus saline in critical ill adults, and that found out the balanced crystalloids actually lowered the rate of composite outcome of death from any cause or persistent renal failure, chronic kidney disease. However, as much as it was a very good study, and people are now sort of ditching, it's not time yet still to ditch the saline, because it was a single-centre study, and there was a few limitations to this study. And people now, before they decide whether saline's still in or out, they're waiting on this PLUS trial, which is Plasmolite versus saline, which hopefully will be published in the next year or two. So, with fluids, type of fluid, we know crystalloids are certainly in. We're not sure what sort of crystalloids. What about the volume? What about restrictive versus liberal? We previously were very aggressive with fluids, and we know that that's not right. Then we've become restrictive, and a lot of the patients come back from theatre pretty dry. We hear dry you fly, wet you sweat. But this article has just came out only a few months ago, and we found out that restrictive versus liberal fluid for major abdominal surgery, restrictive was associated with a higher rate of acute kidney injury. So now we think what fluid is better, and how, and sort of what volume or which way to give it, and this is now more controversy and more lack of consensus. So the next thing is, if we do give fluid, we want to make sure that there actually is a responsiveness. And we've got all sorts of... We want to know, how do we recognise who will respond from fluid bolus or who will have a deleterious outcome? This is a hard question, and unfortunately we still don't have an answer. The bedside JVP is not going to cut it, and all sorts of other technology, including static tests, dynamic tests and ultrasound, have all got their flaws and lack their sensitivity and specificity. So this is still a point of ongoing research, and I think it's pretty exciting. So I think dose response or response to fluid bolus is probably where we need to be going. So what's my approach, considering there's lack of consensus? Well, I've got the Goldilocks approach. So, not too hard, not too soft, just in the middle there. So I don't use ACEs or ARBs on the day of surgery. I don't use diuretics. I tend to be more liberal with my intravenous fluids. I certainly don't use any starch fluid replacements. And I'm still using saline more over the physiological. What about getting the blood pressure up? Well, we know that chronic hypertensives need a higher mean arterial pressure. But we know that flogging them or getting them up too high does not improve the GFR and may have some deleterious effects. Bobby Jean asked me a question about intraoperatively and MAPS, but I don't have the answer for that. But I know that we're just sort of targeting higher MAPS in the critically ill patients or with these AKI patients. Lots of studies have been done with no clear evidence of benefits using dopamine, phenoldiazepam, and a whole lot of other agents that have been tested. Talking about nephrotoxins, there's been a lot of study about contrast and contrast-induced acute kidney injury, and it probably is bigger than what it probably is. We do notice a small increase in serum creatinine with contrast. It occurs between 2 and 5 days after the event, but it's usually self-limiting, and it's not really a major issue, and it generally doesn't progress to chronic kidney disease, except those who have got pretty advanced CKD and who take contrast and they're pretty dry at the time. So I still have a treatment protocol that I use because I want to prevent rather than cure, because there is none, for contrast-induced, and I basically use isotonic fluids at a pre and a post sort of mix, one or the other. I don't really want to talk about renal replacement therapy with acute kidney injury because the jury's not in. We really don't know exactly when to implement renal replacement therapy, the timing. We don't know whether to use if intermittent's better than continuous therapies. What about the dose? Do we do daily hemodialysis versus not daily? We really don't know what the answers are, and also when to continue. But it is very important that if someone is on renal replacement therapy, that they should be followed up in case they're left with some chronic kidney disease. So finishing up, there's a few things. How do we approach AKI? This is not a nephrologist problem. This is everyone's problem. And we're now going into care bundles. I don't know if people have been getting care bundles, but do you want a kidney bundle, a respiratory bundle, a cardiac bundle? How many bundles can we handle? But I really think with the electronic medical record coming, which will pick straight away that you've got an AKI and a stage, because it'll pick up the creatinine going off on 2 consecutive tests. That'll launch, hopefully, something like, be wary, you're in AKI, this is preventable, let's not go down that rocky road. So this is this is sort of what's happening in the world. We've got all these people forming networks, and you've got Stop AKI checklist. You can see the Stop AKI, Think Sepsis, haven't got my glasses, Think Hypoperfusion, toxicity, etc. But there's one. But there's also this lovely little quality improvement study that someone did in the UK, and it's called the Donut Study. And basically they thought it actually did work, and they did actually identify more AKI. And it's very simple. It's dehydration, obstruction, nephrotoxins, urine, and Think Sepsis, which is probably what I've sort of covered through this talk. I think if you gave a staff member a donut, you'd probably have more uptake. And this answers this question: do care bundles really work? And the truth is, as much as I'm not too much for protocolised medicine, but they actually do work. But the problem with the bundles are the uptake. So when people use them, they're very effective, but you've got to get people to use them. And that's the big problem with these bundles. So in finishing off, got to think kidneys. AKI flies under the radar. It's pretty simple to detect, and prevention's the best thing we've got up our sleeve, because there's considerable harm, significant costs. As mentioned, it's preventable, and we can modify the course. and we can certainly get involved with all the touch points across from the preoperative to the discharge of our patients in our perioperative period. And right now we're in a rich vein of research which is quite exciting for this field. Thank you.
Mick Majerison here. On August the 11th, 12th and 13th, the American Association of Nurse Anaesthetists will be holding their annual Congress. Top Med Talk will be coming to you with live updates from the meeting as it happens. We'll be interviewing thought leaders, academics and prominent practitioners for 3 days of discussion and debate. The opioid crisis, enhanced recovery, innovations in anaesthesia and much, much more. Guests will include the president of the AA&A, Gary Bridges, Lynn Reid and Lorraine Jordan, to name but a few. To get ahead of the curve, why not listen to some of last year's podcasts from the AA&A? Simply go to topmedtalk.com and type into the search engine AA&A. Pop that in and you will find our output from last year. In the meantime, of course, if you want to find out more, the American Association of Nurse Anaesthetists are holding their annual Congress August the 11th through till the 13th. Go to topmedtalk.com for more details, and while you're there, make sure you subscribe to Top Med Talk and, of course, that you've joined us on social media. That's topmedtalk.com.